Welcome our dear friends, professors, colleagues, and fellows all over the world. Today is our sixth webinar through our course, our intervention course, the Bifurcation Campus. Today we will begin the second more advanced part. Our first part consisted of 5 webinars regarding the fundamentals of bifurcation, the provisional stenting, the T techniques, the crush techniques, and the keylot technique. Today, we will begin another entity, special situations, and we will continue through another four webinars. Today, the first one of them, today we'll talk about a very special subset of the bifurcation. It is about the left main bifurcation. At the beginning, I would like to thank a dear professor, actually, Professor Dr. Karim Saeed, who had already gave us a lot of his time and experience and his pure science to this channel, the Cardiology Education channel. And I'm sure he will give us a lot today and will take the conversations and discussions to a very high levels of pure science. It is our honor today to have him as the moderator of this webinar. I would like to thank also my dear friends, the CEC board, Professor Dr. Muhammad Zahran, Dr. Karim Mahmoud, Dr. Haitham Sulaiman, and Dr. Ahmed Saeed. They gave a lot of their time and their efforts to Cardiology Education channel. And now it is my honor to introduce our dear speaker today. We have 4 speakers actually. The first presentation, the distal left main bifurcation, a special bifurcation, and the data available and the critical appraisal of Dickey Crush 5 trial. It will be presented by our dear friend, Professor Muhammad Zahran and Dr. Karim Mahmoud. They will give us a very comprehensive lecture about this entity, and that will be followed by 2 cases. The first one is by Dr. Ahmed Samir, the lecturer of cardiology at Cairo University, and the second case will be presented by Dr. Ahmed Saeed, the consultant of cardiology at Shibin al-Qom Teaching Hospital. And now I will pass the mic to Professor Dr. Karim Saeed, who give us a few words as a start of this elegant webinar.
Thank you, Dr. Abdurrahman. Really, I'm very happy to be with you this night, and I hope all are going to enjoy a meeting full of science and interesting cases. As you knew that this webinar will target the major bifurcation, the left main bifurcation. And in the prior webinars, talks were generalized, detailing different aspects of bifurcation. However, left main is a peculiar bifurcation. It is peculiar in its anatomy. It is peculiar in the hemodynamics. It is peculiar in the pathology of atherosclerosis, and in the selection of intervention. Till now, we have a debate whether to go to PCI or CABG. We have a dedicated trial. It is the bifurcation with the many trials, as we are going to see. And it is the bifurcation with the major consequences. If there is stent thrombosis, it is a catastrophe. If it is a restenosis, it is highly symptomatic. And it is a bifurcation that dedicated the use of imaging and the different physiological parameter on its assessment. So we are dealing with a different, unique, peculiar, important type of bifurcation. I hope with this introduction, I'm going to leave you with some interest and several questions that I hope you will have the answer to it through this webinar. Finally, I would like to thank all my friends and colleagues who made this webinar possible. And thank you for you all.
Thank you so much, Professor Karim Saeed, for joining us. It's always a pleasure to have you on board with us, a very highly scientific and eminent profile, as well as a top-class interventional cardiologist. We will learn a lot together tonight. So everyone, tonight is a very heavy night regarding science and regarding intervention. So let's move on quickly because I'm so interested to start this webinar. This is the left main bifurcation intervention. Should we do a PCI or cabbage? This is a lifelong debate. And as we learn from the available data, what we're gonna be showing you. So the left main coronary artery disease is associated with increased morbidity and mortality. This is an unarguable piece of fact, and the significant left main stenosis upon coronary angiography is present in nearly 1 of every 6 patients involved with ischemic heart disease and performing a coronary angio. And as we all know that the cabbage has always been the standard revascularization strategy for this group of patients, and this recommendation is endorsed by both the European as well as the American guidelines that strongly recommend a class 1 cabbage as the treatment of choice for unprotected left main disease, while the recommendation of the PCI is the alternative recommendation that depends upon the decision made by the heart team built upon the anatomical complexity of the coronary artery disease and based upon the syntax score and the surgical risk of those patients. So with the recent development in the stent design and medical therapy over the past decades, several trials have been introduced compared to the older ones, and those have been designed to evaluate the safety and the efficacy of PCI as an alternative to cabbage surgery in patients with left main coronary artery disease. And let me tell you up front that most of those trials agreed upon the point that the PCI treated patients compared to those treated by cabbage had a lower rate of stroke, but they had a higher rate of revascularization. And as you will see upon this will be repeatedly summarized and concluded from every single trial. So what does the data from the trials using old generation DES say? This is PCI by first generation DES versus cabbage for left main disease. This is a meta-analysis of the 4 randomized clinical trials, Lehman's, Syntax left main, Baudrillard, and pre-combat MI. And as you see, all of those patients underwent in the cabbage arm a LEMA to the LED with percentages raised from 81 to 99%. All of them, most of them, 2/3, 3/4 were males. Diabetes was represented between 1/5 up to one quarter up to 1/3 of those patients. And this is the outcomes as you see here. As you see, the stroke as an outcome is very strongly in the favor of PCI. And as you see, the repeated revascularization as an outcome is very favorable towards cabbage. The MACE, if it includes the repeated revascularization, will move towards cabbage, while the death MI or stroke, which we call the 3-point MACE, are usually in the middle line here, indicated that this is not significantly different between the PCI and the cabbage. So with the left main subset of the syntax trial, and let me tell you that the syntax trial was not designed to be as a specific trial for the left main disease, but it was for drug-eluting stent versus cabbage in different situations, including multi-vessel as well as including left main disease as a subset of patient. And as you see that the primary endpoint occurred in 37% of the patients doing PCI versus 31% of the patient with cabbage. And as you see here, the MACE, including the revascularization, 37 versus 31. The death is nearly equal, 14.6 versus 12.8. But the cerebrovascular accident is threefold more common in the cabbage arm, 4.3 versus 1.5. Of course, repeated revascularization is nearly doubled in the PCI, 26.7 versus 15.5 in the cabbage. Okay, if we divided those patients according to the syntax score, we get the low intermediate score, the first and second tertiles. And as you see here, let's see the death is 8% in the PCI versus 15% in the cabbage with a significant p-value. But if you move here to the higher scores, more than 33, and as you can see here, the cumulative event is 46.5 in the PCI versus nearly 30%, 30% only in the cabbage, and the repeated revascularization is threefold, 34.1 in the PCI versus 11.6 in the cabbage of high significance. What does the data from the trials using new generation drug-eluting stents say? This is a question jumps to our mind. I will stop here for a just gentle station with Professor Karim Saeed. I want him to give us his insights about those trials that were used previously in the meta-analysis, including the syntax left main and including the Lehman's, the Boudreau, and the pre-combat. So please, Professor Karim, you have the mic.
Okay, Dr. Muhammad, thank you for this introduction. Actually, I will give just a small comment to grasp your attention toward the syntax trial. Syntax trial used a first generation stents. It was a Taxis stent. And as Dr. Muhammad said, it was not intended to test the left main alone. It was left main and multi-vessel disease. And at the first part of the trial, the multi-vessel disease cabbage was superior to the PCI, while in the left main, PCI had the same outcome to the cabbage. I'm expecting that in the coming slides, Dr. Muhammad is going to represent the data comparing PCI versus cabbage using second and the third generation drug-eluting stent. And when we are going to hear his comments, we should bear in our mind the following points. The first, of course, the type of the stent. In the Taxis, it was the first generation drug-eluting stent with increased risk of stent thrombosis, while in the subsequent trials, we are using a more friendly stent. This is a point. The second point is the endpoints of the trials. They are using the composite endpoint. And usually there is the mortality, the infarction, the stroke, and vessel failure in terms of repeated revascularization. So we are gathering different endpoints under one outcome. And this may not be accepted in some trial. So we are expecting to dissect the outcome of this composite outcome when we are going to talk about the coming trials. The third point, the type of the patient. Left main patients are not a low-risk patients. They usually have multi-vessel disease, usually have some comorbidities. So we are expected to give some details about the type of the left main patients in these different trials. And finally, the long-term outcome, because some trials posed event rate early in favor of PCI, because cabbage is associated with a high risk early. Then with time, there is a catch on phenomena where the event rate increases with PCI and they plateau or even decrease with cabbage. So the syntax trial was a start with a first generation drug-eluting stent with some hint toward equal outcome, but based upon the risk, which is a syntax score. And now we are waiting the comment on more modern trial, using more modern stent and using different advanced technique with some comments on the endpoints. And after hearing this trial, we can wrap up again.
Thank you so much, Professor Karim. You said the key message from the upcoming part of this lecture. So as we know, this was the first part of the lecture. We discussed the trials comparing the first generation DES Minitaxis versus Cabbage, which included Alima. And now we are comparing the new generation stents. So we had the everolimus eluting stent or bypass surgery for left main coronary artery disease trial published in the New England Journal of Medicine in 2016, which we all famously know as the Excel trial. So the Excel included 2,905 patients. Of those patients, the Excel was designed like this. We get the patient and the heart team, including the cardiologists and the cardiac surgeons, have an agreement that this patient is favorable or is eligible to do a PCI or a cabbage. This question was answered by yes in 1,905 patients. So 1,905 patients with low or intermediate syntax score assessed by the heart team on site, because there is another analysis including the heart team that was not on site, aka the core lab. So we have a cardiologist and a cardiac surgeon, and the patient has a left main disease. The cardiologist said, I can do a PCI. The cardiac surgeon said, I can do a cabbage. So this patient was randomized, included in the 1,905 patients, from which 948 did a PCI by the Zyme stent, and 957 did the cabbage. So we are stuck with another 1,000 patients, which from the start either they said, no, this is not a real bifurcation, does not a real left main disease, he will be simply managed by PCI, cabbage has no role here, or this patient is so complex from the start, so he can only be managed by cabbage, and this is what we call the Excel registry, which included 1,000 patients. So what we need to clarify here is that the 126 sites which shared in this Excel study design in those 17 countries across the world, 1,905 patients were assessed by the heart team and were randomized to do a PCI or a cabbage, and on-site assessment agreed that those patients were of a syntax score less than or equal to 32, which is the lower and the middle tertile of the syntax. So what were the results at 3 years? The primary endpoint, as Professor Karim said here, was the 3-point MACE, death, stroke, or MI. And as Professor Karim said, look at the first month here. The curves are largely divergent, and at 3 years, the curves catch up to be convergent at a 15.4 event rate in the PCI and a 14.7 event rate in the cabbage regarding death, stroke, or MI at 3 years of follow-up. Excel included treatment of patients with left main coronary artery disease, low or intermediate syntax score at the point of analysis. PCI was done with Zyme's stent, and we got similar rates of primary endpoint composite of 3-point MACE at 3 years, with fewer adverse effects at the first 30 days compared to cabbage. So the message delivered from the Excel trial was the PCI may be considered an acceptable or preferred revascularization modality for selected patients with left main coronary artery disease, the first and the second tertile of the syntax score, and this decision, of course, should be made after the heart team discussion. This is a very superficial view to the Excel. We will dissect deeply, but I need to give you the same superficial view with the Nobel so your mind can catch up some very big differences from the start. This is the Nobel trials, the percutaneous coronary angioplasty versus coronary artery bypass grafting in the treatment of unprotected left main stenosis, the Nordic, Baltic, British left main Nobel revascularization study. This was done in Europe in, I remember, maybe 36 centers in different European countries. A local interventional cardiologist and a cardiac surgeon at each site assessed the eligible patients with left main coronary artery disease and they included stable patients with unstable angina or acute coronary syndromes, non-STEMI. And I need to mention here that the non-STEMI patients were excluded from the Excel study. But the non-STEMI patients with the rise of troponin were included in the Noble study. And of course, the left main stenosis diameter more than 50% or FFR less than 0.8 in ostium midshaft or bifurcation, not including more than 3 additional complex lesions defined as CTOs, bifurcations requiring 2 stents, calcified or tortuous vessel morphology. What was actually astonishing, this was published in the Lancet, that the primary endpoint MACE here happened in 29% of the PCI patient at 5 years. Kaplan-Meier curves at 3 years, it was 28% versus 18% at 3 years and 29% versus 19% at 5 years. And PCI failed to show a non-inferiority, and CABG was clear-cut superior to PCI regarding the primary endpoint. So the question is, what was the primary endpoint? The primary endpoint was the 3-point MACE, the death, stroke, or non-procedural MI plus repeat revascularization. So repeat revascularization as a primary, as a composite of the primary endpoint was included in the Noble trial, and it was not included in the Excel trial. So what's next? The PCI did not meet non-inferiority for the primary endpoint of the 5-year MACE compared to CABG. CABG was clear-cut superior to PCI. PCI resulted in higher rates of non-procedural MI, we will say that. Repeated revascularization was higher after PCI, and this was primarily due to de novo lesion, new atherosclerosis, non-left main coronary artery target lesion revascularization, revascularization in a new coronary bed. And this was not included at all in the Excel study, but it was one of the secondary endpoints or the composites for the primary endpoint in the Noble. And also point number 5, the all-cause mortality was similar between both PCI and CABG. It was 11.6 in the PCI, 9.5 in the CABG. It was non-significant. The non-procedural MI was 7% in the PCI, 2% in the CABG. The repeated revascularization, 16.2% in the PCI, 10.4% in the CABG. I want to tell you that the Noble left main stenting techniques, bifurcations was 88% of the cases, left main to LAD single stent 60% of the cases, left main to LCX 4% of the cases. Kilot technique for bifurcation 2 stent strategy was in 24% of the 36% of the patients that needed 2 stent strategy. Kilot technique represented 2/3 of all patients that underwent a 2 stent strategy. The DK crush or the crush was only 4% of the cases. IVUS was used in 74% of the patients in the Noble and in 80% of the patients with the Excel, and the kissing balloon was achieved in 93% in the 2 stent technique in the Noble. Let us dig a little bit deeper to compare what happened here. The all-cause death was non-significant in both trials. It was 8 versus 6 in the Excel, 12 versus 9 in the Noble. The cardiovascular death, 3.7 versus 3.4 in the Excel, and 3% equal between both in the Noble. The myocardial infarction, and here we come to what we need Professor Karim to explain to us. The periprocedural myocardial infarction, the definition, because we have the 3rd universal definition and we have the 4th universal definition for periprocedural infarction with rise of cardiac enzymes in the cabbage as well as in the PCI 3x, 5x in the first definition, and then 5x, 10x in the second definition. In the Excel, 3.8 versus 6%, which was significant. In the Noble, 5 versus 7, which was not significant. And the non-peri procedure, which is not related to the procedure, was 4.3 versus 2.7, non-significant in the Excel, versus 7 versus 2%, highly significant in the Noble. The other endpoints, the stroke, for example, 2.3 versus 2.9 in the Excel, 5 versus 2 in the Noble, very high. In the PCI, higher than the cabbage. This is very strange to have a patient that did a PCI and gets a stroke higher than the patient that did a cabbage. And here we get something related to the stent, the definitive stent thrombosis. What happened? Here with using the Zyme stent, it was 0.7%. Using the biometric stent, it was 3%. And this was compared to saphenous venous graft occlusion, which happened in 5.4 of the cabbage patient in the Excel versus 4% in those with the Noble. And repeated revascularization, it was not an endpoint in the Excel. It was not included in the composite primary. In the Excel was 13 in the PCI versus 7.6 in the cabbage, while in the Noble it was 16.2 with the biometric stent versus 10.4. Regarding those 2 points, the definite stent thrombosis, the revascularization, maybe the stents performed differently. And before I pass the mic to Professor Karim here, the question is like this because we get the same idea if we are focusing together on what I'm saying. Did the Excel patients really include relatively less complex left main disease in terms of syntax score? Because you said that the higher tertile of the syntax was a reason for exclusion. Well, when I was explaining this point, I told you that the on-site heart team included the first tertile and the second tertile only. And as you see here in the PCI, 60% first tertile, 40% second tertile. In the cabbage, 61 and 38. But the core lab analysis later on, those who sit and calculate the syntax score accurately, the third tertile was represented in nearly 25% of the patients in the PCI and in the cabbage. So actually, we may debate, did the Excel trial really include highly complex patients or not? And this is the core lab data. I will stop at this slide. I will pass the mic to Professor Karim Saeed. He will raise some important questions and answers that will help us all to learn the needed data from the previous slide. Please go on, Professor Karim.
Thank you, Dr. Muhammad. The first comment is the fact that the recruited patients and the enrolled population in the Excel and the Nobel are not the whole left main population. Can you hear me?
Yes, Professor Karim, I'm hearing you very well.
So, as Dr. Muhammad delineated, for example, in the Excel, about 3,000 patients were investigated for enrollment in the trial. However, less than 2,000 were actually randomized. And the second point in the inclusion, both surgeon and interventionist should agree that they can achieve safely and effectively revascularization for patients. So when we want to get a conclusion from this trial, we should know that these are selected type of left main population. In terms of they can achieve revascularization both by surgery and PCI, and that high risk or those who cannot be accepted easily by the surgeon for some comorbidities or by the interventionist because of some challenges in the PCI were excluded. This is a point. The second point, now we are using drug-eluting stents with the second and the third generation. However, they are not the same. In the Nobel, the stent used were the biometrics, and the Excel were the science. And definitely we have some subtle and may not be similar in the performance. We have some data that may point to some difference in the performance of these two platforms. The third point, the endpoint. Both trials have different endpoints. And this is a major problem, because when we weight mortality and give it the same weight as stroke, and give it the same weight as revascularization, and we give it the same weight at myocardial infarction, this may not be fair. Mortality is a mortality. And when we look to mortality, there are some points. For example, in the Excel, there is signal for increased mortality at 5 years, total mortality. However, the authors negated that the trial was not powered to discuss or to show results of mortality. It was a composite. And the increased mortality was related to non-cardiovascular mortality, which is strange. Cardiovascular mortality was similar between both arms. This is related to mortality. The same for myocardial infarction. We have data that procedural myocardial infarction carries less risk, if it carries any risk, for long-term event compared to non-procedural myocardial infarction. And as Dr. Muhammad said, we have different definition or modified definition for the term procedural in terms of the number of fold of increase of the serum cardiac marker. And even for the term of myocardial infarction, the Excel used two different definitions, the SKY definition and the force universal definition of myocardial infarction. The message here, it is a very complex and challenging to get a clear answer, which is better, PCI or CABG. We have different population, selected population. We have different type of stents. We have different composite endpoints. We have different definition of each of the endpoint of these composite endpoints. And finally, we have different outcome between those trials. So maybe the most important is to know that each patient should be treated separately. Those patients at increased risk of stroke, such as the elderly, so we will take the message of the syntax. CABG is associated with increased risk of stroke. Let us decrease the risk and consider PCI at a higher level. This may not be an evidence based upon this trial, but this is a message that can we have from this different type of data. Okay, we can continue with Dr. Muhammad, then we have a final comment.
Thank you so much, Professor Karim, for elaborating these important points, actually, because this is very important for us to know that the different patient profile, the different definitions of MI, and including or not including the repeated revascularization got us different results between both trials. So although the investigators actually recruited only patients with low and intermediate syntax score, up to 1/4 of those patients in the Excel who underwent randomization had a third tertile syntax score according to the angiographic core lab analysis. You should know that there was a difference in the long-term medication, especially the dual antiplatelet therapy between the PCI and the CABG, and of course a longer-term follow-up is needed. The noble limitation is the difference in the primary endpoint compared to the other one, to the Excel, and the low response to the event rate made the Kaplan-Meier interpretation up to 5 years in the first trial, but this was actually confirmed in the 5-year result. And take care that there was a fraction of the patient that was actually treated by the first generation biometric stent and this particular stent has a bigger strut thickness above most of the types that are currently used. So this is a comparison between the Excel and the Noble, which would say, let's look at the inclusion criteria: significant unprotected left main coronary artery disease or left main equivalent, or including ostial LAD and ostial LCX. That's what we call the 011 bifurcation. In the Excel, clinical and anatomical eligibility for both patients as agreed by the local on-site heart team. Silent ischemia, stable angina, unstable angina would included, but those with a high elevation or elevated biomarkers were excluded. In addition to the randomized patient, they have the registry, as Professor Karim said, that those are the ones that were obligated to PCI only or obligated to CABG only. In the Nobel, they included acute coronary syndrome patients, they included non-STEMIs, they included those with myocardial infarctions, and the definition was a significant unprotected left main coronary artery disease, but not 3 additional non-complex lesions, as we said, the CTOs, the bifurcations, and the patient eligible to treated by CABG and PCI by the local heart team as well. So the main exclusion criteria in both, let's say that the important one is the angiographic exclusion criteria more than 33, which was included or excluded by the local on-site heart team. But then, as they said later on, that the angiographic core lab analysis said that 25% were in the third tertile. And here exclusion was in the presence of left main coronary artery stenosis plus 3 complex additional lesions, as we said previously. The primary endpoint here is a 3-point MACE: death, MI, or stroke. Here, death, stroke, non-procedural MI, and new revascularization, PCI or CABG. This was 1,900 patients, 131 sites across the world. This one was 1,200 patients, 36 sites over the Europe. The main result at 3 years, the primary endpoint was nearly the same. Here at 5 years, the primary endpoint was 10% different, 28 versus 18%. And the conclusion here, both of them, the CABG and the PCI was non-inferior to CABG, but here the CABG might be a better than PCI option. So what do we conclude from here? The Excel is a trial with the contemporary standards of PCI, best-in-class DES, IVUS in 80% of the patient. CABG on-pump surgery was done in more than 80% of the patient, all of them receiving edema. The non-inferiority of PCI was met for the meaningful range of endpoints, which is the 3-point MACE. The results are largely explained by the less peri-procedural MI in the PCI group, using the SKY definition of 10-fold, using the third universal definition of 5-fold and 3-fold, but an important catch-up phenomenon occurred in the MIs up to 3 years, which may require a later follow-up. This was what happened in the Nobel, that this MIs was in new areas other than the areas that were revascularized previously. The Nobel, a very long enrollment period because the number of sites and number of centers were less, great perseverance, number of patients was less. The trial reported 5-year Kaplan-Meier at that time, but now we have the real 5-year results. It's the same, 29 versus 19. In the first one was 28 versus 18, so it's the same. Difference in the Excel was driven by MI, revascularization, and stroke, while difference with the Excel explained by the different MI definition. As we said, the SKY, the third and fourth universal definition, inclusion of repeated revascularization of the primary endpoint in the Nobel, but not in the Excel, and the focus on the longer term follow-up. But here you need to notice, as Professor Karim said, that the design of the stent made a difference. We had a more significant stent thrombosis with this particular stent compared to the Xience or the everolimus eluting, which has the lowest stent thrombosis between all the drug-eluting stent. What we can conclude from here, that both studies showed that for treatment of patients with left main, PCI was non-inferior to CABG with respect to overall and cardiovascular death. And this was agreeing even with the older studies versus the Texas stent. The result of the Excel suggests that PCI with the Xience is an acceptable sometimes preferred alternative as the heart team discussed to the cabbage in selected patients. And two-thirds of the patients with left main disease may be eligible for PCI, the first and the second tertile, and approximately 80% may be eligible for cabbage because all tertiles would be eligible for cabbage. I finished. This is a much shortened lecture than it should be, but we need to move on. I will pass the mic to Professor Karim Saeed while Karim Mahmoud will start sharing his screen. So please go on, Professor.
Thank you, Muhammad. So the question that we have now, is it straightforward to do PCI to left main? The answer, we don't have a clear answer. The guidelines, the revascularization guidelines by the European Society in 2018 based the recommendation upon the syntax score. So if you have a patient with left main and low syntax score, it is class 1 to do PCI. If it is intermediate score, it is class 2A. If it is a high score, it is class 3, contraindication. And of course, cabbage carries class 1 recommendations. Of course, these guidelines were before the publication of the long-term 5-year outcome of the Excel. And the Excel, when it was published, as was shown by Dr. Muhammad, it reported similar outcome between PCI and cabbage. However, there was debate within the steering committee of the trial about the signal of increased mortality and the definition of MI. And upon this debate, the European Association for Cardiothoracic Surgery withdrew its support for the recommendation of the 2018 guidelines. And the results of the Excel were not considered as a recommendation till now. And despite the presence of some meta-analysis that may give some insight, till now there is uncertainty regarding the strength of evidence and the consistency of recommendations favoring PCI in left main disease. Until we have more strong, consistent, valid, agreed upon evidence, we should approach every left main case patient by patient, taking all evidence from different investigations and in a heart team discussion. And of course, the main point is the experience and the outcome of each center in its result in PCI versus cabbage. Because even in the Excel trial, some centers showed superiority in the PCI arm versus the cabbage, while other centers showed the opposite. So a very confounding factor that all of us cannot be sure of is the impact of the experience and the impact of the center team upon the result of the intervention, whether it is PCI or cabbage. We have a question from Dr. Karim. Because Dr. Zahran said the myocardial infarction, the non-procedural, was less with cabbage. And Dr. Karim asked whether cabbage protect Karim.
Yes, Dr. Karim, I was asking about.
Me?
Yes, I'm with you, Dr. Karim. I'm asking about the definition of peri-procedural MI in the Excel trial and consequently in the Nobel trial. Can we? I think it depends mainly on the CKMB, which is abundant now to be used according to the universal definition of the myocardial infarction. So can we depend on this definition, and can And is this definition affecting the results of these trials? So, Muhammad,
I think, Karim, we have a connection problem with Dr. Karim Saeed.
I think Dr. Karim was us again. Dr. Karim?
Yes, yes. Sorry, Karim, I lost a connection with you.
No problem.
Okay.
So I was asking about the definition of peri-procedural MI in both trials. Can we depend on this definition now in the light of updated universal definition of MI? Can this seemingly old definition affect the results of these trials?
Okay. In the Excel, when they used the sky definition, they ended up with a favorable outcome of the PCI in comparison with the cabbage. However, at some point of the analysis, they announced that they are going to use the universal definition of MI. However, they didn't report this definition. And they said that the data were not available. Complete data were not available. However, in a subsequent release, they reported the full disclosure of the universal definition of MI across the Excel, and it was higher across the PCI group compared to the cabbage, and this was associated with increased outcome or worse outcome in the PCI arm compared to the cabbage. However, Greg Stone, the main author of the Excel, defended his point that the definition of procedural MI was not consistently associated with long-term worse outcome. This is debatable, and many evidence support the sky definition and validate the sky definition in terms of its association with outcome. So it is an open question till now, and it was associated with a battle between surgeons and the interventionist after the publication of the trial, and actually some recommend the retraction of the Excel manuscript based upon the difference in the reported definition. So even the authors cannot give us a final comment, and so it is an answer till now, Karim.
Okay, thank you, Dr. Karim. And moving to the second part of this nice webinar. Actually, it will be a short part in discussion of the DK Crush 5 trial, as the DK Crush 5 now is an emerging technique for dealing with the left main bifurcation involving the ostium of the LCX. It is the illustration of the DK Crush technique that depends mainly on the placement of the side branch string with complete coverage of the side branch ostium. Then the deployment of the side branch stent, and after deployment, some authors recommend withdrawal of the stent balloon and doing a high pressure inflation to ensure complete apposition at the site of the side branch ostium, then crushing with a non-compliant balloon in the main branch, and after the crushing, doing rewiring and the first kiss. Then deployment of the main branch stent This main branch stent, we go and do a rewiring and do a kissing balloon inflation. The kissing here should be sequentially, starting with the side branch, doing a high pressure inflation at the side branch to ensure the apposition of the side branch stent, then doing a final kissing balloon inflation, and this is the final result. So the DK crush studies passed with a relatively long journey, starting with DK crush, the original trial, DK crush 1 and DK crush 2 and DK crush 3, reaching to DK crush 5 in the 2017. Looking into the first trial, DK crush 1 compared the DK crush with the classical crush. The DK crush did favorably in regarding the reduction of in-stent restenosis. In the DK crush 2, the DK crush was compared to the provisional stenting in the non-left main bifurcation, and again, DK crush was favorable regarding reduction of the stenosis in the main branch, side branch, and the major adverse cardiac events. Then to the left main, and here is the DK crush 3 comparing the DK crush with Kilot technique. Again, the DK crush showed a favorable result with the reduction of the composite mass as shown here, that mainly driven by reduction of target vessel revascularization. So here I'd like to ask my friend Zahran. What do you think about the most common site of the failure of these two stent technique? I speak about the DK crush and the Kilot technique.
Yes, dear Karim, thank you so much. This is a very important technical point that was met upon and led to lots of studies with QCA, because as you know that the 2D angiography that we do is a two-dimensional image of what we are seeing, which is actually a three-dimensional image. And the idea or the concept of polygon of confluence as the point where you have the point of confluence, which is the center of the intersection, or what we know as the point of the bifurcation, which is actually located proximally in the mother.
Muhammad, are you with us? So Haitham, are you with us?
Yes, dear.
So we have a connection problem also at Zahran. I think he was speaking about here we're speaking about the most common site of in-stent restenosis that observed in the DK crush and the Kilot technique, and the most common site with the ostium of the side branch, and here this diagram showed that the origin or the area of confluence here was associated with the most common incidence of the side branch stenosis, and here the side branch stenosis in the Kilot technique was 12%, and in the DK crush 3 was 6%. So DK crush 5 was published in 2017, and it includes a patient with unprotected left main with Medina classification 111 or a 011, meaning we have a side branch or circumflex disease. So here a 282 patient is randomized to a provisional stenting technique, and 282 patient randomized to a DK crush technique. and the follow-up was intended to be at this interval, and we at the 2017 we have the result of 1 year follow-up of the DK Crush 5 and the primary.
I'm sorry, I was disconnected, but you may continue and we can say this point later if you want.
No problem, no problem. So the primary endpoint in the DK Crush 5 was defined as target lesion failure. Target lesion failure includes 3 items: the cardiac death, the target vessel myocardial infarction, and target lesion revascularization. And they added a safety endpoint, which was the stent thrombosis. So,
Karim, can I have an observation here?
sure.
In the inclusion criteria, and this is very important, they included a Medina classification 111 or 011.
Yes.
So, and this is a practical point, the golden question that we are all facing when dealing with the left main bifurcation, that considering the ostial stenosis of the LAD or the circumflex is an extension of the left main disease.
Yes.
And this is a point to be taken into consideration, that there is no isolated ostial LAD or ostial circumflex disease without an extension into the distal left main.
Exactly.
So they included the criteria of 011 as an indication for extension of the stent or intervention into the distal left main, because there is no such thing as an ostial isolation of ostial disease of either LAD or circumflex. This is a point to be taken into consideration.
Thank you, Haitham. This is correct regarding the extent of atherosclerosis. Yes, in the distal left main disease, we have the atherosclerosis is extending into the ostium of the LAD and the ostium of circumflex. However, the other point is to be included in the study that the diameter stenosis is more than or equal 50%, meaning that giving a 1 to circumflex, it should have a diameter stenosis of a 50% or more. So regarding the follow-up and the 1 month follow-up, here the composite endpoint of target lesion failure was more in the provisional stenting. And this was driven mainly by, at the first, by the cardiac death. The cardiac death here, we have a 4 deaths in the provisional stenting and no death in the DK crush. The incidence of stent thrombosis, there is a trend that the stent thrombosis was higher in the provisional stenting arm. After 1 year, the target lesion failure again was significantly higher in the provisional stenting, that was mainly driven by target vessel myocardial infarction, with a trend that the target lesion revascularization was also higher in the provisional stenting. Regarding the stent thrombosis was also high in the provisional stenting arm. So here, the 1 year follow-up showed some superiority of the DK crush over the provisional stenting for the left main bifurcation 111 or 011. And this is the advantage of the DK crush. It is a 2-stent strategy and has some advantages, that is 6 French compatible, and it achieved more reliable final kissing balloon inflation and achieve better stent side branch coverage, and it is not dependent on of angle. Remember, one of the predictor of the failure of Kilot technique is increasing the angle of bifurcation. And in the left main bifurcation, here we have an angle that more than 70 degrees. So this is one reason that DK crush may be preferable than Kilot for dealing with the distal left main lesion. And for that, the European Society of Cardiology in the 2019 myocardial vascularization gives the double kissing crush technique a 2B recommendation over provisional T-stenting in the true left main bifurcation. However, there are some drawbacks of the DK crush. Let's start first with the technical drawbacks. first one, this is upfront two-stent technique. So you can't start with one stent and do the second stent. You are deciding to do a two-stent technique from the start if you choose the DK crush. Second point, this involves many steps, and if you fail any of these steps, you might have failed the whole procedure, and you might not achieve the best result that achieved in the clinical trial. So it needs an experienced operator. The third point regarding the triple layer that you achieve with in the DK crush. And the fourth point is achieving of the kissing balloon inflation and the final kissing balloon inflation. Here is a report from the Nordic 2 and the BBC 1 trial that showed that the crush technique have a failed kissing inflation in the 20% of cases in comparison with the kilot that have a failed kissing of 9%. So the failed kissing also endanger the success of your procedure. And this is one last technical point that I want Dr. Mohammed Zahran to share his opinion regarding this point. And Dr. Mohammed Zahran, do you think is there a possibility of rewiring outside the stenting area in the DK crush?
Yes, Karim, there is a possibility, and that's why they gave you two tips regarding performing the DK crush. The first tip is allowing an adequate area, an adequate length of the stent to be crushed. And number two, after you inflate the main vessel stent, after you inflate the side branch stent, you need to withdraw the balloon into the main vessel and perform another inflation. So the ostium of the side branch is inflated by the main stem of the balloon rather than the edge of the balloon, because the force is concentrated at this main stem. This is very important. So you assure that the stent is very, very adequately opposed at the ostium of the side branch. So when it is crushed and you are performing the rewiring procedure, you do not pass, as you show here in your grid diagram, that the wire will pass in the raw area, which is not covered, and you will inflate the balloon and you will end up with deforming the stent at the ostium of the side branch, and this will create restenosis, which is actually what you were trying to avoid from the start by performing this technique. Just one point about the polygon of confluence, because we got disconnected here. What is peculiar about the left main as a bifurcation and the polygon of confluence, you do not apply this polygon of confluence to an LED diagonal to a circumflex OM. It's not important. But here, if we are speaking about the left main, as you can see here, that the restenosis rate in the kilot technique is 9.2% at the polygon of confluence versus 4.5 in the DK crush. And this is because the kilot technique creates a new carina, a new bifurcation. The kilot technique, you get a new polygon of confluence of bifurcation of the left main. And this creates different velocities other than the naturally created velocities and naturally created shear stress forces. The higher the shear stress forces, the higher the atherosclerosis you get. Remember, in our very first lecture explaining the atherosclerosis, we said that the carina, which is the central part of the river, has a higher velocity. So you do not get atherosclerosis of the carina. You get atherosclerosis opposite to the carina. At the river bank, you get all the mud, you get all the soil, you get all the atherosclerosis. So if you create a new carina and you disturb the natural shear stress forces, atherosclerosis is doubled in the kilot technique at the polygon of confluence compared to the DK crush, nearly double. What is the polygon of confluence? You draw a straight line at the ostium of the LED, at the ostium of the LCX, and at the distal left main, and you draw a circle with the central point in between those three. This circle central point is the point of bifurcation, and those three lines touching the margins of the circle is known as the polygon of confluence. Thank you so much, Ken.
So thank you, Mohammed. And I have here a comment also from Dr. Ahmed Samir regarding the wiring of the side branch stent. And again, we recommend the proximal position of the recrossing to, as we see here, if we achieve a proximal position of the rewiring, we can ensure that we have our stent inflated and we avoid such a silly complication in the side branch. So there is a critique for the DK Crush 5, and this is regarding also that bot was done as a final step in the provisional stenting, and there's no bot done prior to recrossing in the provisional stenting. And 47% of patients in the provisional arm had a crossover to two stents. The final casings was done in 78% in the provisional stenting, and actually it's almost all patients in the DK Crush technique. So this is another diagram regarding the target lesion revascularization on 1 year. And I'd like also Mohammed Zahran to tell his insight regarding this final part of the diagram on the follow-up. What do you think, Mohammed?
This is also very strange and mind-blowing. You see the curves. The curves start at 0, 1, 3, 6, 9 months. The curves are overlapping because this is clinically driven revascularization. The patient said, I got chest pain. He goes to the hospital. He performs the regular procedures. He does a coronary angiography. You see a lesion. You perform the lesion. This is the gold standard practice. But what happened at 12 months? It looks like suddenly all the patients in the provisional stent arm, suddenly, all of them decided to get a chest pain at 1 day in the morning, enter the hospital, and suddenly, this chest pain is double significant of the 3.8%, and suddenly all of them did a revascularization. It looks odd. The curves, even if the curves should diverge, they will diverge across a period of time, not suddenly diverge at 12 months. This is a very important point of criticism also for the DK5.
So despite it's a good trial, it has some limitation, as we mentioned, the limitation regarding the technique and regarding the design of the study. And of course, every study has some limitation. However, I believe we will hear some other insight from Dr. Karim. To finalize this part, I'll talk about the 3-year follow-up that recently published for this trial. And compared with 1 year follow-up, the 3-year follow-up was comparable regarding the reduction of the lower target lesion revascularization in the patient with provisional arm. And here is driven by reduction of target vessel MI and target lesion revascularization. Remember, in the first year, there was a trend for a higher target lesion revascularization in the provisional arm. However, in 3-year follow-up, there was a reduction, there is a significantly higher target lesion revascularization in the provisional arm. Regarding the stent thrombosis, again, the stent thrombosis that was higher, the probable stent thrombosis was somewhat higher in the patient with provisional arm. So before reaching the conclusion, I'd like to hear some comments from Professor Dr. Karim Saeed regarding this trial.
Thank you, Karim, for this thorough discussion for the DK Crush 5 trial. Actually, you have shown all the comment, critique, and the limitations for this single trial, upon which the revascularization guidelines recommended this technique for distal left main disease. If I want to add a comment, the first comment is related to the fact that the angiographic lesion in the circumflex in this trial, the average length was 16 millimeter upon inclusion. So we know that when the side branch here, the circumflex, is involved by this length of stenosis, from the early start to stent strategy is recommended, not the provisional one. And this is a major limitation. The second limitation, it is not a limitation, it is a strange observation. When we look to the rate of definitive or possible stent thrombosis, in the provisional, it is 4%. In the decay crash, it is 0.4%, tenfold increase in the risk of stent thrombosis without possible pathophysiologic explanation as early phase of this trial. Decay crash is a Chinese technique, and it is supported by many Chinese based articles that promoted its use. Still, we want more data about the long-term outcome of this trial. However, it makes the procedure more lengthy, but it's easier for crossing and recrossing of the balloon into the stents, and this was a limitation of the standard mini crash technique. There is a modification for the decay crash, which is called the nano crash. After you implant the side branch stent, you withdraw your balloon halfway, then you do the kissing with this balloon and the straddling balloon in the main branch. So you will oppose the stent into the carina, and by this step you may skip the first kiss. It is proposed, but it is not still validated from the benchmark point of view. It is logic. The final and the important comment raised by you and by Dr. Zahran and by Dr. Samir: wire recrossing in all bifurcation stent occur as a distal stent struts, except with crash. It is from the proximal or the middle, and the longer the crushed stent, the more space you can go into the side branch to be the middle, and the shorter the crushed stent, the necessity to your wire to be at the most proximal strut of the stent. Thank you, Karim, for this important presentation.
Thank you, Dr. Karim. And this is the final conclusions. So we have some advantage, some cons and some pros. Regarding the cons, this is the decay crash is a technique for a complex bifurcation lesion involving the side branch ostium. It has a good clinical result, but of course it's based on a single clinical trial. It is a 6 French compatible and achieves better side branch ostium coverage, and it is not dependent on the angle. However, it's upfront to stent technique. It has many steps. It's a single based on a single trial, so it should be it needs some reproducibility in future trials. And it's in the complex left main lesion, as Dr. Karim mentioned, we should decide a two-stent technique from the start and not doing a provisional stenting if we have an extensive side branch disease. So thank you so much, and I think this is the time for the amusing part of the webinar, and moving to my friend Dr. Ahmed Samir. He will show a very nice case of the left main bifurcation. So Ahmed.
Thank you so much, Karim Mahmoud, for this wonderful lecture. We're glad to announce Dr. Ahmed Samir, lecturer of cardiology at Cairo University. Ahmed is one of the eminent interventional cardiologists in Cairo University. He has a very good case of left main bifurcation intervention with the use of intracoronary imaging to decide upfront his strategy, sizing, and landing zones and everything. So please, Ahmed, you can start sharing your slides from the from the green button down there, please.
Thanks, Dr. Karim. Thanks, Dr. Zahran. Very glad to be with you today, and very honored to join the team for Cardiology Educational Channel in the presence of Dr. Karim Saeed as well. In short, my case was a challenging left main case that we had double trouble. It was an 82 years old male who is diabetic and hypertensive on therapy, but with no follow-up, so we did not have any data about his control. He has a crescendo pattern angina over the past 1 month that was peaking to be angina at rest in the last week. Upon presentation, he gave us history of persistent severe typical chest pain for 9 hours prior. It was apprehensive restlessness and severe agony, and thus it was not cooperative at all. This was his ECG at presentation. It has a right bundle that we presume that it was something recent. ST depressions almost in all leads with ST elevation of 1.5 millimeters in AVR. So we were dealing with something big. We had bedside echo that was a limited study showing a preserved overall contractility, hypokinesia in the anterior, anterolateral, anteroseptal segments, moderate mitral regurgitation. We rushed for coronary angiogram. We did it from 6 French right radial approach. He had CT of the right coronary artery with multiple levels of subtotal, total, tandem lesions. But on the right side of the screen in the epicranial view, we showed despite the CTO of the right coronary artery, though it gives an island in the proximal LAD, retrograde filling into the proximal LAD island means that we will have another surprise in the left system. Jumping into the left system, we have seen in our non-ST elevation acute coronary syndrome octogenarian guy a distal left main mounting towards subtotal occlusion, and this distal left main apparently gives rise to at least 4 branches that we can see by now, with an aneurysm that from this view looks to be at the proximity of one of the 2 smaller middle branches, the maybe remi. In the spider view, the LAO caudal view, we have more insights into the distal left main disease. And now the aneurysm is apparently to be more related to the circumflex proximity with significant haziness mounting to subtotal occlusion in the proximal LAD and haziness with the tight stenosis at the proximity of the circumflex as well. This is epicaudal view, more or less giving the same illustrations as was seen in the LAO caudal. The on-site surgeon was called immediately for her team discussion while the patient is still on table. Despite the targets were very favorable for surgery, but his opinion was considering the age, the frailty, the expected troubles in post-operative care and mobilization for such an octogenarian patient. The surgeon believed that we should do what we can do and give us the lovely smile that we can expect. Accordingly, we upgraded the access to right femoral artery 7 French. We used the sign black wire to be advanced through the subtotal proximal LAD lesion, and it was placed distally, and a BMW wire was advanced into the circumflex. Actually, wiring the 2 remi or whatsoever branches was not attempted, not to make the system very sticky and very crowded. We performed quick pre-dilatation to the left main LAD by a 320 millimeters NC Trek balloon. We considered having a non-compliant balloon in the start to overcome any calcifications. Sorry, it's not very obvious here, but we will show it in a sec. After the post-dilatation, the LAD flow improved a bit, but not significantly. But at least now we can rush and perform intracoronary imaging to understand more where the aneurysm rises from and how this anatomy is in 3D appearance. This is a pullback coming from the mid LAD, from the healthy part of the LAD, going backwards, quantifying the branches and evaluating where would the side branches are. This is the calcific tight stenosis at mid LAD. These are a few branches coming from the LAD. Apparently, this was the diagonal. Again, a calcific long lesion in the proximal LAD. Here we have seen the aneurysm. And after the aneurysm is closed, we see the other wire that is at the circumflex. This means that the aneurysm is in the proximal LAD, not related to the left main, not to the circumflex, not anything. For more emphasis, I pushed the IVUS distally and back again proximally to ensure this piece of information, because it will be a critical piece of information to ensure that the aneurysm is really related to the proximal LAD. Despite all what we have seen from the angiography, apparently from the angiography, it was related to either the rami or the circumflex. However, the IVUS show unequivocally that it is related to the LAD, and the LAD shrinks into the normal caliber before the wire of the circumflex gets into the view. Accordingly, this was the relatively healthy landing zone that we considered. This was the tight lesion in the mid LAD that was immediately distal to the diagonal branch. This was the origin of the diagonal, obviously. The fourth image was the long calcific lesion in the proximal LAD. This was the site of the aneurysm that we have been sure now that it is related to the LAD proximity. And this is the entrance of the circumflex wire. Again, entrance of the circumflex wire into the left main. And this was the left main shaft with a black burden that was quantified by the IVUS to be in the range of 60 to 70%. Majority of the black burden was approaching towards the left main distality. And this was the histopathology of these different levels of IVUS imaging. And thus we have a clear strategy now. We opted for fixing the left main into LAD first, and I put the proximal stent first, and I will, after the case ends, illustrate why I decided to do this counterintuitively. We implanted a 4x30 millimeters onyx balloon all the way towards the covering the left main ostium to the aorta to have enough room and be safe to perform proper POT. This was deployed at 16, then was pulled a bit and did more ostial flaring at 24 atmospheres. Then it was overlapped distally by another 338 Zions Albine drug-eluting stent covering the way towards the landing zone in the mid LAD that we have decided by IVUS. It was deployed at 14 atmospheres, and then the overlap was post-dilated at 24 atmospheres. Then, by non-compliant balloons, we optimized by a 320 non-compliant balloon in the distal part of the stent, and by a 375 in the proximal part, and the LAD stent. After this step, we performed POT and ostial flaring. which was accomplished by a 4.5 by 20 non-comprined balloon. This was the angiographic result after putting the stents. And I guess we all agreed that the part of the left main bifurcation and the origin of the circumflex needs to be further evaluated. But alhamdulillah, and for God, thankfulness and gratefulness, the side branches, the small side branches that were coming from the proximal part of the aneurysm, related either to the aneurysm or to the left main, were still intact. The aneurysm size generally became a little bit smaller than what it was, and possibly this because of relieving the obstruction distal to the aneurysm, reducing the pressure inside. This was the IVUS run coming from mid-LAD backwards. Apparently, the distal part of the stent, the distal edge of the stent, was a bit still compressed. Here was the origin of the big diagonal, the proximal calcific part of the LAD and the aneurysm at 11 o'clock. Then the wire of the circumflex. The left main stent appeared well opposed, but still it can be better to be post-dilated further. And thus, the 375/20 millimeter non-compliant balloon was used to further optimize and post-dilate the distality of the stented segment, while the 4.5 was in the proximal part of the LAD at the site of the aneurysm, and the two mostly diagonal branches arising from within the aneurysmic part. And lastly, there was a bigger 520 non-compliant balloon for final optimization of the left main, final pot, and ostial stent flaring. This was our end result in the AP cranial view comparing the pre and the post. And I would like to draw your attention to the size of the aneurysm. How did it shrunk after relieving the obstruction that was at its distal part? And in the right caudal view, the circumflex ostium was almost not affected, and our case went very smooth and sharp with provisional stenting after revealing the ambiguity of the anatomy with intracoronary imaging. The patient came out from the cath lab of pain. The ECG changed dramatically, improved post-intervention. Retrogradely, we knew that he had non-STEMI after having the biomarkers that were withdrawn at baseline before entering the cath lab show up the results. He was discharged from the hospital in 2 days. The patient was completely asymptomatic and follow-up visit after 2 weeks, and thus we did not consider playing around in the right coronary for this octogenarian man. The take-home message was that intracoronary imaging is quite helpful in left main interventions. Presentation with acute MI is not an exception to that rule, provided it does not delay reperfusion. Angiography alone can be very misleading in describing a complex 3D anatomy, and better understanding of the anatomy of the anatomical complexity of a lesion can aid to a simple and a quicker solution. Thank you.
Thank you so much, Ahmed Samir. This was a wonderful case presentation. And it shows us that provisional stenting can always be performed adequately and meticulously, and you can achieve very good results. You do not need to waste your time opening small right coronaries to gain some fame. You just saved the patient's life, so you did the job. And this is what we actually care about. What I actually like here is what IVUS showed us, because not every one of us has IVUS in the cath lab. Ahmed Samir showed us that a 4.5 non-compliant balloon inflation in the left main was not enough, and you needed a 5 millimeter balloon. So let me tell you, Ahmed, that I learned from you and I learned from lots of my friends working IVUS, and I learned from lots of papers doing meta-analysis, and maybe Karim and Professor Karim Saeed will support me with that, that usually most of the left mains are 5 millimeters and more. Very few left mains are 4 millimeters. So it's very unwise to end up with a 4 millimeter stent in the left main, and you will say, I inflated it at 16, I did the job. You can put a 4 millimeter at 16 in the proximal LED, but if you are going to do a left main, please consider dilating it with a 5 millimeter balloon if you do not have an IVUS. If you have an IVUS and you do the IVUS, you probably will use a 5 or even a 5.5 millimeter balloon. What would you like to add, Professor Karim Saeed?
First of all, thank you, Ahmed Samir, for this very challenging case that ended with a very good result. And thank you, Dr. Zahran, for your valuable comment. I have some comments and some questions to Ahmed. First, for Dr. Zahran question, yes, the left main is usually accommodating 4, 5, and even 6 millimeter balloon. The problem is that with atherosclerosis, there is remodeling of the blood vessel, and we think this is the main true, the true lumen of the artery, while it is a remodeled vessel. And when we go with a large balloon at a high pressure, we may end up with rupture of the left main. So yes, the left main accommodate large balloon, but we should be very cautious in sizing and in the pressure, the high pressure, because of the phenomena of positive remodeling, especially in the left main. And in this particular case, if we use the simple Murray law, if we have an LED of 4 millimeter and the circ not less than 3 millimeter with this ramus, so the sum is more than 7 millimeter, and we can expect that the left main is 2/3 of this 7 millimeter, so it is approaching 4.5 at least in diameter. My question to Dr. Ahmed, first, you managed a very high risk patient, 80 plus year old, coming in acute coronary syndrome, occluded right coronary artery, high risk anatomy, in left main, the presence of aneurysms, atherosclerotic aneurysm. You opted for IVUS that proved to be very informative. It provided a very valuable data regarding the proximity and the origin of the aneurysm, the presence of calcification at the LED, and the sizing. I have questions for each of the vessel. As I just showed, there is a complete arc of calcification at the LED. Did you consider the use of any debulking technique before implanting a stent in this calcified vessel? This is for the LED. For the circ, many operators will opt to do a kissing balloon inflation after this crossover technique, left main to LED, to optimize the flow into the circumflex. Of course, this was not supported by good evidence, but this is a traditional step in many operators. And the third one, IVUS definitely have showed that this is a large left main, 5 millimeter. So why did you go for 4 millimeter and 4.5 millimeter from the start? Why not to start with 5 millimeter short balloon, not 4.5 millimeter? Thank you, Ahmed.
Thanks, Dr. Karim, for the very elegant and demonstrative questions. Regarding question number 1, the IVUS showed that there was a complete arc, but apparently it was a thin and a very superficial arc. And when I tried using the 3.5 and 3 by 20 non-compliant balloons, which is more or less 1-to-1 sized to the vessel, it inflated properly and efficiently without any waste. So I assumed that by the inflation of the non-compliant balloons, I overcome the calcium. I cracked the calcium already. This was even before the IVUS. For the question number 2, yes, doing kissing balloon after provisional stenting is the tradition for some schools, but not for all. And it is controversial. I do believe that if the circumflex from pre and post deployment of the left main to the distal left main, proximal main vessel to the distal left main, the distal main vessel stenting, if it was not affected, not compromised, not anything, I would rather not to do the kissing balloon, not to dissect the proximal part or the origin of the side branch, and not to buy trouble mandating or dictating putting a side branch stent as a second step. The last question, I'm sorry, was it?
The 5 millimeter balloon?
Yes.
Rather than the 4.5 millimeter balloon.
The left main was in the IVUS was obviously more than 4.5. However, I sized the left main LAD stent according to the LAD size, which was 4 millimeters by max. So I deployed the Onyx, which we all know that the expansile capacity exceeds the other stents. So I put it and was planning to do the optimization and put by the 4.5 balloon, which proved not to be enough to overcome all the resistance. And thus, after the final IVUS, we upgraded it to 5.
Thank you, Ahmed. We have a question from our colleague, Dr. Muhammad Abdel Masoud, asking why did you started with stenting the proximal left main LAD? Okay.
Actually, this might be a bit off-label. However, by tradition, if we put the distal stent first, in many occasions, we find some difficulties in the proper sizing of the residual length of the lesion in the proximal part, where if you get it, the stents that are planned to be used a little bit shorter, you will go for a third stent with a longer overlap inside the left main. And if it was longer than the size that you predicted, you will end with a very long overlapping segment inside the first stent. And thus, when the proximal landing zone is the aorta and you do not have any room to manipulate it, traditionally, and again, this might be off-label, but I found it quite helpful, I put and optimize the landing zones of the proximal stent first. Then I can imagine and do whatever I want in the length of the residual part of the distal lesion. However, I am putting quite sure in mind to to post-dilate the overlapping zone very well with a non-compliant balloon, approaching the size of the proximal stent.
Ahmed, can I rephrase this question?
Yes, sure.
The concept or the idea for most of our fellows is that if we put the proximal stent first, this will decrease or make it harder to deliver a distal stent. So do you have any tips, or can you explain the technique that will make it easier to deliver the distal stent while putting the proximal stent? Because the common concept is that if you deliver the proximal stent first, this will make it more difficult to deliver any metal distally to this stent. You will have some technical problems. So can you clarify this more?
I would agree strongly with this concern if this was a tortuous part of the vessel, and if this stent was a small stent. Having a small and narrowed lumen with the corrugations of the metal with a sharp bend or bends would make this concern very ideal and very appropriate. However, in a straight part of the coronary tree, the left main towards the LAD without any sharp bends and with a 4 millimeters diameter stent, onyx stent, that was even implanted at a super nominal pressure, I would not be very concerned for the difficulty of delivering the second stent.
Okay, Ahmed. Of course, we have some situation that can we place a proximal stent before a distal stent.
Yeah.
My concern in this situation, if I place the proximal stent and the distal index of the stent within a plaque in the LAD, and this cause the dissection, and I am now compromising the flow to the ostium of the circ, and if I have a double hit at the distal index of the stent and the circumflex, this may be a big challenge to solve. While placing a distal stent and making a good judgment for the size, the length of the stent at the proximal segment of the artery, if I have the choice to select between different stent lenses on my shelf, this may be more safer. But of course, you did it good and well.
You did a great job, Professor Karim. I would like to add, actually, from a real life experience, in 99 out of 100 cases repeatedly, what Dr. Ahmed Samir did is would go on safely. But what Professor Karim raised is an important point, and what actually Ahmed Samir said, if you have a mid-LED, which is a little bit tortuous, just a couple of days ago performing an intervention that involved a very long atherosclerosis from the ostium down to the mid-segment of the LED, which was bended. And after performing, which was a heavily calcified, by the way, and after performing a good pre-dilatation with non-compliant balloons, what we got was a big dissection and a total occlusion of the mid-segment of the LED with a collapsing patient. And since this was a very calcified vessel which did not pass a long stent, so we decided to give a short stent because this was bifurcating with a big diagonal and a big septal. The coronary circulation was compromised and the patient was collapsing. So we decided to put a short stent in the mid-segment to seal the dissection, and then we would put another stent proximally and another stent distally. And guess what? We ended up by a procedure that we burst up 9 balloons and 2 guide liners until we succeeded finally to perform the revascularization procedure to pass the distal stent to the stent that we already inserted in the mid-segment, which was a 275 by 18, and it was on a bend in a calcified patient. We broke a guide liner and we used another guide liner so we could deliver the stent distal to this stent successfully and complete our procedure. So what Professor Karim Saeed is saying is very, very, very logic and safe. What Ahmed Samir is saying is in a specific situation, as he said, down to the proximal, let's say the left main, the proximal LAD, and down to the first bend of the LAD at the bifurcation, usually with the second diagonal. This is a straightforward area, straightforward vessel, which usually is 4 millimeters down to 3.5 millimeter in size. You can put a stent proximally and then you can put another stent distally. But if you are doing this in a mid-segment or beyond the mid-segment of the LAD, in a tortuous and calcified area, where even although we were obligated in that case, I was explaining to you because the patient collapsed, but we still suffered a lot to do the distal stent after we put the proximal stent. So for, let's say that this is a rule of thumb, to put the distal stent first and then the proximal stent, unless you are very experienced. And number two, as Dr. Ahmed Samir said, it's a straight part of the vessel. You don't have curves, you don't have calcium, and you have a big profile of the vessel. The width of the vessel, the diameter of the vessel allows you to pass a stent through the first stent. I think Ahmed Saeed is ready now to share his slides. This will be the second case and also everyone is welcome to moderate with us. So please go on, Ahmed Said.
Good evening, my dear professors and colleagues. So I have some cases demonstration of left main intervention. So this is the first case. This man presented with non-STEMI. So this is his coronary angio. It's clear that there is a distal left main disease, but it doesn't look significant. But here we have the ostial LAD and also the mid LAD, the proximal LAD, eccentric lesion. This is the angiogram. So here I will go fast. The plan was to go for direct stenting from the left main direct to the LAD provisionally. Of course, wiring, oh, sorry. So, of course, wiring both vessels, the LAD and the left circumflex. And here we went for stenting that segment of the LAD first before we go to the left main LAD. This is the test and this is the positioning of the stent. And then deployment. So this is the second stent extending from the left main, overlapping the other stent. And this is the deployment of the stent. In our center, the protocol is to go for the pot and then to recross to the side branch of the LCX. We don't leave the carina covered with the stent struts. We open it. We do the kissing balloon and the final pot. So here we cross to the LCX. We did the kissing balloon. And this is the final pot. Here, the LCX from the beginning didn't look significantly diseased. That's why we only did the kissing and the final pot. So the second case scenario is almost the same as Dr. Ahmed.
Ahmed Said, thank you for the first case. I'd like to ask you and Dr. Karim, when you decide to do an intervention to the LCX after doing the left main stent, in other words, how would you choose doing after a provisional stenting to the left main to do a further intervention, whether a kissing balloon or a tap technique to the LCX?
Actually, personally, or for our center preference is to go for recrossing and to open the carina for the LCX. We consider the LCX a big vessel, so it needs a kissing balloon. And not to be covered with the struts crossing over to from the left main to the LAD. It could be like a nidus for thrombosis later on for the side branch. We consider this bifurcation. We consider the LCX is a major side branch that needs at least to open the carina with a kissing balloon and a final pot.
So we as a routine.
Yes, it's a routine. We open the struts for the side branch if it is the LCX.
Okay, my question to Dr. Karim, what do you think about? I think there is a lot of operators that recommend doing a routine kissing balloon inflation after provisional stenting. So, Dr. Karim Said, what do you think about this routine strategy of doing a kissing balloon inflation? So I think Dr. Karim have some problem with connection.
Okay, I am with you, Karim.
Okay, Dr. Karim.
For non-left main bifurcation, non-left main, such as LED diagonal, many operators do not think it is mandatory to perform this casing balloon. However, some data showed not doing this may be associated with increased risk for angiographic restenosis, but not clinical outcome. It is not associated with worse clinical outcome at all. This is for the non-left main bifurcation. For left main bifurcation, also we do not have data, but many operators prefer to do this casing using a short non-compliant balloon at the circumflex. But again, it is not supported by evidence to show improvement in clinical outcome.
So what about the experience? What's your experience regarding that, Dr. Karim?
Okay, if the
I know you didn't like this question, but
okay,
I'd like to ask every operator here what about his experience regarding.
If there is no pinching at the circumflex, I don't do it.
Okay, what about you, Samir?
I'm with the school that I do not do it unless I angiographically have evidence that it is required. To avoid overdoing it with a non-compliant balloon, having a dissection in the left main, in the circumflex, and dictating another unnecessary stent.
Okay. So the answer
and you,
is not here.
And you, Karim, you what do you do? And Dr. Zahran and the other.
Usually, I don't do a routine kissing balloon insulation except if I have a significant pinching or an impairment of the flow into the LCX.
I don't do it actually. I support myself by what we said that in the Nobel trial, we had a record that 68% of the provisional stenting did not do a kissing until I attended the European Bifurcation Club meeting 2 years ago with Karim Mahmoud, and we saw a lecture from a doctor from anatomy that said that the post-mortem analysis of all the patients who did left main LED stenting and died from stent thrombosis, they had a series of 10 patients, and 7 of them had thrombosis at the ostium of the circumflex, which extended to the left main, and this was angiographically normal. And then she started explaining the idea that you never know what is standing opposite the ostium of the circumflex. It can be an open strut, or it can be a piece of metal, or it can be the welding between the pieces of metal. So it can be something very thick that initiates thrombosis, or it can be nothing at all. So since you never know, it's better to make a routine opening of the strut at the circumflex. But actually, she did not mention that you need to do it with a one-to-one balloon or a non-compliant balloon to cause a dissection or something like this, because putting a stent in the ostium of the circumflex has a very poor long-term prognosis, and most of these stenosis occurs at this site particularly. So if I see a pinch, maybe I would go with a 2mm balloon just to open this flow for any future intervention, but I would not go for a one-to-one balloon, and I would not go for a kissing balloon unless I do a two-stent strategy. This is my opinion. It's not mandatory for anyone, but just it's a collection of many opinions.
So
Yes,
thank you, Ahmed, for raising this debatable issue, and continue with the second case, please.
Yes, yes. Again, just the last comment. Our issue is to prevent the thrombosis of the side branch. We consider the LCX is a significant side branch. So this is only for the left main. We do it as a routine kissing balloon and the final foot to prevent the thrombosis.
Okay. I want to kick this question back to Professor Karim.
I have a case. I have a case also for like this one. It's typically like this one. I didn't put today. I was about to put, but I know the time. That there was an ostial LCX dissection from the kissing balloon that mandated another stent.
Yes, Yes,
It was clear from the beginning.
Yeah.
It was clear normal, not normal, but it was not significant disease, ostium of the left circumflex, and it did a dissection, and the patient had the chest pain after the kissing balloon that needed another stent, and it ended up with the TAP technique instead of.
Professor Karim Saeed, I would like to ask this question. If you are going to open, if you decided that you will open this strut opposite the circumflex, would you go for a smaller balloon or would you go for a one-to-one balloon? Professor Karim Saeed, are you there?
Okay. Inflating a balloon, even if it is a 2 millimeter balloon, towards the circ will cause a deformation at the opposite side at the roof of the left main. So if I'm going
after that, maybe after you do the inflation, you will do a pot. So it's a pot side pot.
The pot, yes, the pot may correct this. The pot will correct this. But my rule is either to do the kissing if it is indicated, or not to deform the stent struts.
So much, Professor Karim. Ahmed, go on for the sake of time, please.
Okay.
So please, Ahmed, continue your.
Yes, this is the second case. She is a diabetic hypertensive lady. She presented with severe agonizing chest pain with significant ST depression in all the pericardial leads, with ST elevation in the AVR, and that was the coronary angio. Here we notice the significant stenosis at the distal left main. It's like a 0-1-1 ostial LAD and ostial LCX, that hazy lesions. So here we have significant difference between the caliber of the left main and the LAD and the left circumflex. So what do you think your plan will be in this case with significant chest pain, diabetic hypertensive, blood pressure is 90/60, and this 0-1-1 lesion?
Karim Mahmoud, would you like to comment on this case?
Yes.
I think the problem is mainly in the critical lesion in the middle AD. I know that we have a disease involving the ostia of both LAD and the LCX, but the subtotal occlusion is mainly in the middle AD. So first I fix the middle AD, then I'll do this is a complex lesion in the distal left main. It can be done with the Dickey crush, as we mentioned, or TAP technique, whatever you choose.
Sorry, Dr. Ahmed Saeed, are we sure that we are dealing with distal left main bifurcation, or this is an early diagonal and the circumflex is the very small branch that comes like 15 millimeters earlier?
Okay.
Maybe.
But look at the distribution of that vessel in the iliocaudal, sorry. It will come again here. So this distribution is not a distribution of diagonal. It's at least, if you can say, a ramus, and that one is the LCX, but it is not a diagonal at this level in the caudal view. It looks like it could be a ramus, yes. And here, this side, it doesn't go for the. This is the right cranial. It doesn't go for the diagonal course, I think. This one.
So it's a complex bifurcation lesion also. I think it's Medina 0-1-1. And we have a critical lesion in the middle AD. So let's see what you have done.
We have here, our thinking was the unstable or about to be shocked. She was not shocked at that time, but she was compensated with the tachycardia. The second thing, the discrepancy in the caliber between the LAD and the LCX and the proximal with the left main. And the acute situation with the severe chest pain at rest, even during the coronary angio, that was not controlled with the analgesic even. So our decision was to go for a V stenting. We inserted the 7 French guiding catheter and of course wired both vessels, and simultaneously we put the 2 stents at the same time for the LAD and the LCX, and we did simultaneous inflation with the dots just inside the left main, so the both stents are just kissing each others at the ostium. And that was the result after deployment. We have chosen the LAD stent to cover the mid-segment lesion, and then we did the kissing balloon with the 2 non-compliant balloons new, and that was the final result.
So it looks angiographically nice, Ahmed. So I'd like to ask Dr. Karim about the current rule for using such techniques such as a V-stent or SKS stent in the current practice. So what do you think, Dr. Karim?
Okay. I will first comment on this case, then to discuss the V-stenting technique. Definitely the culprit lesion in this patient is the mid-LAD, which is a subtotal one. And we have good left main or functional left main, and we have a plaque at the proximal LAD and another plaque at the proximity of the circumflex. I cannot judge whether it is this severe to mandate stenting now or not. My strategy in this patient is that I will fix this culprit subtotal LAD lesion, and if the patient is stable, I will postpone any intervention at the time being to judge later on the functional significance of the LAD and circumflex using FFR. The V-stenting is a good technique for rapid bifurcational cases, such this case, when patient is in shock or in bending shock. And the problem, it has 2 problems. The first problem, if dissection occurred proximal to one of these stents, it will be very challenging to manage this proximal dissection. The second, sometimes it ends with simultaneous kissing stent, and we will have a jacket, 2 stent at the middle of the left main. We cannot be very sure that we adjusted the stent at the exact ostia of the circumflex and the exact ostia of the LAD. I don't like the V-stenting in general, but sometimes in a crashing patient, V-stenting or SKS stenting technique may save the patient.
So I think the key message here, as Dr. Karim mentioned, that this technique should be reserved for the hemodynamically unstable patient with critical bifurcation. So I'd like to ask you, Dr. Karim, another question regarding the use of the functional assessment and the FFR in the distal left main lesion. We know the rule of IVUS and how we can assess the left main with IVUS. But what about the functional assessment of the left main? Do you recommend such a technique for assessment of the functional significance of the left main?
Okay. You mentioned we know the use of IVUS. Actually, we don't know the use of IVUS for the assessment of the severity of the lesion of the left main. It is not recommended to assess the severity of left main lesion using the IVUS. Of course, we have the cutoff of 6 of the IVUS and the 5.5 for the OCT, but it is not recommended. the recommendation is to use physiological assessment. And for physiological assessment, it is FFR, not IFR, because we do not have till now validation of the use of IFR for lesions at the left main. It is FFR. And when we use FFR, it should be done at both directions, towards the LAD and towards the circumflex. And if one of each vessel proved to be less than 0.8, so this left main should be fixed.
Okay. Thank you, Dr. Karim, and thank you, Ahmed, for showing this nice case. You can proceed now.
Sorry. We have this patient. He is post-cabbage and with a patent lima to LAD and an occluded graft to the ramus branch. The distal L6 was not grafted before. Here also there is a significant lesion. No, the graft to the ramus was occluded, and he was presented with the non-STEMI. So here there is an ostial total occlusion of the ramus branch with a distal left main diffuse disease till the LCX ramus. So our strategy was to wire the ramus and to balloon it. Of course, sorry. Of course, wiring was a little bit challenging and difficult. That was the workhorse wire. It couldn't pass. We tried many wires. Even the polymer jacketed wire like the fielder didn't cross. So after that, we tried the Pilot 200 that could cross to the ramus. We will see in the coming video. So here all these trials to wire the ramus. So here wire was put in the LCX, and this is the other wire trying to cross to the ramus branch. That was a 7 French guiding catheter. When we go for any complex intervention, we are expecting to use or to face a challenging situation. We go for the 7 French guiding catheter. This is the Pilot 200 that could cross to the ramus branch. We are trying to pass the balloon. It passed with difficulty, then pre-dilated with the 2 millimeter balloon. Then tried to pass another 2.5 or 2.75 balloon. It didn't pass, so we went for a 2.5, another 2 shorter balloon, and then we pre-dilated the ramus till it's ostium with the left main. So here, this is a protected left main distal bifurcation intervention. The lima to the LAD is patent, so no need to go for any intervention or even trying to wire the LAD. This is pre-dilating the ramus with a 1-to-1 balloon, and then we did the mini crush technique. Here we're inflating the side branch stent first, and then removing the balloon and removing the wire, and then stenting the main branch, which is the left main LCX with the drug-eluting stent, crushing the side branch stent, then recrossing from the proximal edge as we mentioned, And that was the test to be sure that we are crossing in the proximal, and then opening the struts and doing the kissing balloon. Inflation. And then the final put. Oh, sorry, that was the result. And then we did the post dilatation of the ramus stent, and that was the final result. What do you think, Dr. Karim?
So thank you, Ahmed. Actually, it's a relatively large ramus branch. I'd like to hear comments from Dr. Karim regarding the intervention, and I'd like to ask about this is a left main trifurcation with, however, the LED is protected by the ramus. But I'd like to ask also about the cases of left main trifurcation in the patient who is unprotected left main trifurcation. What are the tips and tricks for managing such cases?
If it's a distal left main trifurcation, here we have to, I think from the beginning, we have to go for the 7 French guiding catheter, wiring the 3 vessels if the ramus is a big branch. Even if a small branch, we have lost ramus before, even we thought it is a very small, but it was causing significant chest pain for the patient. Even it was looking very, very tiny and very small, that we had to go, and even we opened the flow to that ramus with a 1.5 balloon, and then the pain resolved. So we have to go for 3 wires. If it is a 1-1-1-1 trifurcation lesion, so we have to use at least 2 stent strategy. I think that the DK crush or the step crush is the most appropriate here. So not to have any protruding metal inside the main branch, because tap technique, which one you will put the side, the ramus or the left circumflex. So mini or step crush or a DK crush, considering 2 stents is the best rather than putting 3 stents. Sometimes if the angle is good, we can make it just as a T stenting technique, the classic T stenting without any protrusion. If the angle is good with the left circumflex and the left main LAD.
So, Dr. Karim, and what do you think, Dr. Karim? Ahmed mentioned some steps of left main trifurcation. I'd like also to ask you about your comments and about the final kissing inflation and the number of the stent used in the left main trifurcation.
Actually, when we are talking about trifurcation, they are very heterogeneous. Sometimes we ignore this third branch if it is a small or tiny. If there are 3 large branches, we pre-dilate all. Then we decide the technique based upon the angles and the size of the branch. Sometimes we do 2 crush at the same time. We place a stent, for example, in the circumflex, another stent at the ramus, and the balloon at the left main. Then we crush the stent of the circ and the ramus after their inflation. Then we place a stent left main LAD. Then we do kissing circ left main, ramus left main, and we end by tracing by 3 stents, by 3 balloons at the circ, the LAD, and the ramus. This is the most advanced scenario to do 3 stents by crush technique at 3 sizable trifurcating branch. But in many times, we end by 2 stents, usually crush or decay crush. And the third one is dilated by a balloon and also by tracing and the final pot. This is for the strategy for trifurcation. The question in this case, we talked about the decay crush. Why we opted for the traditional mini crush in this case? Why not?
Ahmed decided to do a mini crush from first. Yeah, I think we talked about the decay crush, and here's the question for Ahmed. Ahmed choose here mini crush. So it may be an old case, or he may be.
Yes, Karim, it was 2014.
Okay.
It was before the era of decay crush, actually.
But now you will go for decay crush.
Okay.
Yes.
Ahmed, may I have a comment, please? Regarding the trifurcation Karim Mahmoud asked about, and the very valuable data Dr. Karim Saeed told us. Actually, we will have a webinar just for the complex trifurcation, which is a more advanced level, mostly of left main disease. I have a few cases which I used many techniques. I used the 2 guidings, which is called the ping pong technique, so I can do 3 balloon inflation at the same time. Also, we can do stepped or simultaneous kissing between LED and Ramus and LCX. But actually, what I want to comment is a question that Professor Dr. Karim Saeed asked Zahran about the kissing and provisional stenting. Actually, to do a very good provisional stenting, that you can oppose the struts of the main vessel against the ostium of the side branch. What I mean is you can extend your struts 2 or 3 or 4 millimeters inside the ostium of the side branch if you do a very good bot, and you can do kissing. For me, I do kissing now for every provisional stenting I do. I do it with a 1-to-1 balloon. That is the question from Muhammad Zahran. You can undersize if you have a side branch of 3 millimeter. You can do it with 2.75. If you use a non-compliant balloon and you have a very minimal struts inside the side branch, when you do a very good bot, and then you can recross from the very distal strut. When you cross from the very distal strut, you can oppose 2 or 3 millimeters of the main branch stent inside the ostium of the side branch. I don't know if Professor Karim Saeed can agree with me regarding these points of final kissing inflation in provisional stenting or not.
Thank you. As I mentioned, the evidence to support routine final kissing balloon after provisional stenting is not strong. I am aware of a study that showed that routine follow-up by angiography is associated with increased risk of restenosis when we do not do this kissing, but this is not associated with worse clinical outcome. So we discover the restenosis by angiography, but the patient does not complain. But of course, not all bifurcation are the same. If it is a large branch, we may think still doing the kissing may help. But we do not have an evidence to support this.
Yes, thank you, Professor Karim. I think, of course, we don't have enough data, just the experience of our experts like Professor Dr. Karim Saeed. But I think the rationale behind the final casing is just, do you know, Professor, the idea behind why not we have to have a true bifurcation, we must extend the ostial disease of the side branch more than 5 millimeters, because when we do a very good opposition or both to the main vessel stent, we can will oppose 2 or 3 millimeters of the main stent struts inside the ostium of the side branch, especially if we recross from the very distal strut. I don't know if Karim Mahmoud want to comment.
Thank you, Ahmed. Thank you, Abdurrahman, for these lovely comments. I think you have a very good points, and you and Dr. Karim regarding this issue. So I'd like to ask you, Haitham, if we don't have any last comments from the YouTube.
No, actually, we do not have any
Okay.
other comments from the YouTube.
So if so, I think I'd like to thank Ahmed Saeed for these very nice cases. I think we have reached to the end of this very nice webinar. I'd like to thank the presence of Dr. Karim Saeed and Dr. Ahmed Samir among us today for their valuable contributions. I'd like to thank Dr. Muhammad Zahran for his elegant presentation, Dr. Ahmed Saeed for his nicely done cases, Dr. Abdurrahman and Dr. Haitham for moderating the YouTube, and Dr. Abdurrahman also for moderating this whole course of bifurcation. Thank you all. Meet you on Thursday. We have a very important webinar on mitral regurgitation, how to image, how to intervene. So wait us next Thursday, inshallah.
Thank you, everyone, and
Thank
see
you,
you
Dr.
next week, inshallah. Bye-bye.